In this video, what I'd like to do is to give you an understanding of how to interpret the results of a hearing test. So a hearing test is a fairly simple process. Normally you'll be fitted with a set of headphones, red on the right and blue on the left, and then you're asked to say yes or press a button whenever you hear a particular tone. If the sound is even very soft, you've still got to respond that you've heard the sound. And those results are then recorded on what we call an audiogram. And so you've probably seen a graph similar to this from your audiologist. So the graph itself is very simple, very easy to understand. So your hearing, if it was normal, would be a straight line across the top of the page at 0. That's where it ought to be. If your hearing gets all the way down to 120, that's when the hearing is all gone. That's when there's nothing left. So we'd say at that point, you're stone deaf. Now, most people, thankfully, are not at that position. Most of the people that we would test on a regular basis are going to have some type of hearing loss, a hearing impairment. So it's a little bit like having an eyesight problem. Your vision isn't 100%, but you're not blind. Most people with a hearing loss obviously find themselves in that category. So in this particular graph, you'll see there are two lines. There's a red line and there's a blue line. So the red always corresponds to the right and the blue corresponds to the left. And in this case, the two lines are very similar and they're fairly close to the top of the page. There's a grey box right here, and this grey box basically indicates what we call a speech banana, and it shows you where all the different sounds in speech typically lie. If your hearing is above this grey box, in this white area right here, then we would say that your hearing is still within a normal range. It may not be perfect. Perfect is on 0, but if it's within this white area above the grey box, then it's still within a normal range. Once your hearing drops into this grey box, that's when you develop a problem that would normally require some type of attention correction. Once your hearing drops outside this grey box, below it, then that's when the hearing loss becomes quite critical, and that's when the loss would be a severe loss typically. So the further down the page your hearing goes, the worse your hearing loss is and the more need you have of having a correction to your hearing. So as we go down, it represents the loss in decibels, and as we go across this way, the sounds get sharper. So it's like a keyboard on a piano. The tones over here on the left are very deep, over on the right they're much sharper. So in terms of speech, the deeper tones will be sounds like ah, oh, ma, ba, da, and the high frequency sounds will be s, f, t, ch. So they'll be the much sharper sounds. Now, as far as speech is concerned, all the sounds are important. It's important that you hear the full speech spectrum. Whenever part is missing, that's when you're going to start to have issues. So let me just run through a couple of graphs with you so that you can see various types of hearing losses. And then I'm also going to show you another test that we do, which basically is designed to give us an idea of where the loss actually is occurring in the ear physically. So now when we look at this particular graph, it's not dissimilar to the original one. On these lower and mid frequencies, it's very much the same, but on the very extreme high frequencies, it takes a bit of a nosedive. And you can see it drops quite rapidly down to around about 80 decibels. Now, this is a very borderline case. It'd be very difficult to know whether or not we would want to correct this loss. It, to a large extent, will depend upon the issues that the particular client is experiencing. Some people with a minor loss have a lot of troubles in communicating. Other people seem to make a little bit of information go a long way. So it's not everyone who needs correction. If this person was really struggling, then obviously it would be a good idea to trial a set of hearing aids on that person. However, if they were really experiencing no difficulties whatsoever, they were understanding everything pretty much that was being said, they weren't turning their television up, then we wouldn't consider any need for a hearing aid. Now, in contrast, if we have a look at this particular graph, instead of it just being isolated on the extreme high frequencies, this graph drops away much earlier, right in here in the mid frequencies. And so even in the mid frequencies, you've got at least a 40 decibel loss, and then that very rapidly drops again away down here to around about 60 or 70 and further. So this person is experiencing a lot of trouble. So these types of losses, however, can be a little tricky in the sense that sometimes the client has a lack of awareness. What these types of people will normally say, well, I can hear okay. Just occasionally I might misunderstand if somebody's mumbling or they're not speaking quite loudly enough. But other than that, really, my hearing's not too bad. Now, what tends to happen is that people get conditioned to their hearing loss. It's a slow process. You gradually lose it, so you're not all that conscious of just how much hearing you've lost. Not until we correct it. So this type of hearing loss, what I would typically expect this person to be saying is that in a quiet environment, I may be able to understand you, but as soon as I go into a difficult environment, in other words, either someone's not looking at me, they're a little further away, or there's any background noise, I can hear you, but I can't understand. The reason they can hear you is because the low frequencies are still okay. They're not too bad. So the person hears the ah, the o, but they don't hear the s, f, t, ch. So they may miss 50 or 60% of the sounds that you're actually producing when you're talking with them. And so what they're doing is they're having to fill in the gaps as they go. So they'll hear part of a word or they'll hear part of a sentence, and they're now having to mentally do gymnastics and try and put all of that together. And so these are tricky losses, but they are very, very much in need of correction. Now, the other thing I just wanted to point out was we do typically 2 hearing tests when we test your hearing. So the first test is with the set of headphones, and in that case the sound travels down through your ear canal, it strikes the eardrum, and then it goes through the middle ear where you've got the ossicles, the 3 little bones in the middle ear, and then the sound vibrates, the last bone in the chain vibrates against an inner eardrum into the inner ear, which is the cochlea. And in the cochlea, there are approximately 20,000 tiny microscopic, what we call little hair cells. You can think of them as maybe little nerve endings. And so these nerve endings respond to that sound pressure wave as it enters that chamber. And then those little nerve endings, they will vibrate, and they'll basically create an electrical impulse that travels up the auditory nerve to your brain, and then you hear. So the first test we do with the headphones goes through that entire mechanism. The second test that we'll do, we use what's known as a bone conductor. And a bone conductor is a little vibrating pad that just sits on the bone behind your ear, on your skull. And in this case, the sound is vibrated through the skull directly to the cochlea. So we're bypassing the middle and the outer ear. So in this case, we then plot not just these noughts and crosses, which are the right and the left ear, but we also plot little brackets. And in this case, the brackets are exactly the same as the noughts and the crosses. So in other words, when we go through the skull to the nerve, bypassing the outer and the middle ear, we get exactly the same degree of hearing loss. That means that the problem is obviously in the cochlea. It's in the nerve. Now, with what we call a sensory neural hearing loss, these losses typically are permanent. Other than maybe if you've got a bad head cold, something like that, then you may find that it may be a temporary loss. You've got an ear infection. However, for most of these, if they're noise-induced, if they're drug-induced, if it's a cardiovascular issue, anything like that, like a hemorrhage, then these are going to be a permanent loss, and these are the ideal candidates for a set of hearing aids. Now, the alternative to that is a hearing loss that looks more like this. Now, in this case, if we look at the blue, which is the left ear, it's within a normal range. The right ear, however, that's quite a severe loss. And if we have a look at the bone conduction results of the right ear, instead of it following exactly the same pattern, the right ear bone conduction results are sitting right up here at the top of the page. So what that means is that when we put the sound through the skull and we go directly to the nerve, we're actually getting a good result. That means the nerve is healthy. So if the nerve is healthy, why do we have this loss? the reason we have that loss is because there's a problem with the outer or the middle ear. Now, it could be as simple as some earwax blocking your ear canal, but the audiologist would normally have had a look there before we do the hearing test, just to make sure the ear isn't being plugged. It could be a perforated eardrum, it could be the bones in the middle ear have calcified and are locked together, it could be fluid in behind the middle eardrum. It could be the bones actually having snapped and broken. So again, the eardrum's just sitting there flaccid. So there's quite a number of different scenarios, different reasons why you may have what we call a conductive loss. Now, a conductive loss is often operable. So when we see these types of losses, we would typically refer you to an ear specialist, and we would do further tests to be able to isolate and work out exactly what the nature of that problem is. And then you would consult with the specialist to see whether or not the surgery was appropriate. Now, sometimes our clients have seen a specialist, the specialist happy to operate, but maybe the client just doesn't feel comfortable in doing that. Maybe they're quite elderly, they don't want to go through the extra trauma of having surgery at that age, in which case then they can still elect to have to be fitted with a hearing aid. A hearing aid will work perfectly well with these conductive losses, with most of them, unless you've got a discharging ear. If you've got a really bad infection, a cholesteatoma, something like that, you really need to get that addressed. You don't want that to remain unattended. So, but again, totally different loss, and you can see this type of loss is very flat, whereas the previous loss, when it's a noise-induced type hearing loss, which may be caused by, farmers sitting on tractors with noisy exhausts, or people who've gone shooting or working in noisy factories, normally it'll be these high frequencies that are affected, and the lows are quite good. With most, not all, but with most conductive losses, we find they tend to be flat, and some of them actually taper upwards on those high frequencies. So again, a different pattern. So we get quite familiar with looking at these various patterns. Okay. And then in this scenario, this final one, if we have a look firstly at the left ear, this is a hearing loss where the low frequencies are good, the high frequencies are bad, and the bone conduction shows us that it's a sensory neural loss. It's the little nerve endings that are damaged. This person has no option but to wear a hearing aid in that left ear if they want to hear better. With the right ear, different scenario, different story altogether. You can see here, no response at all the way down here, 120 decibels, client can't hear a thing. So this is what we would term a dead ear. Basically, there is no response at the maximum sound presentation of 120 decibels. And when we did the bone conduction test, we can only test down to about 70 decibels on that test, and at that level there was no response. So basically this would be an ear that a hearing aid would have no chance of being able to correct. So this client could do one of three things. They could wear just a single hearing aid in the left ear. They could use what we call a bicross, which is where we would, in the right ear, we would put a half a hearing aid, which would be a microphone to pick the sound up from the right hand side, and then a transmitter that transmits the sound to a hearing aid in the left ear that picks the sound up from the right hand side. So the left ear does all of the processing, all of the hearing, but you'll be able to hear from both sides of your body, doing all the processing through the left ear. And often people opt for that. And that can work quite effectively. Certainly if you're in a situation where you're sitting in a car and you're in this scenario, if you were the passenger trying to hear the driver, then you'd be really struggling, even though the left ear is, it's a mild to moderate loss. If you were to wear the bicross, you would have no trouble then being able to hear the driver. So in situations where the person you're wanting to listen to is isolated on that bad or dead side, this works well. And then these days, your other option with a loss like that would be a cochlear implant. And this is where you'll actually have a device basically drilled into your skull with a little electrode into the skull. You'll still wear a hearing aid behind the ear. but it enables people with no hearing whatsoever to be able to hear again. So in that situation, again, you'd be referred to your ear, nose and throat specialist, who would then assess your suitable ability for that type of process. So the audiograms, it's a very, very useful tool. It's not everything. We need to know other things. When it comes to actually programming a hearing aid, however, this is what we use as the basis to be able to develop what we call a prescription, to be able to amplify all of the different sounds according to your particular requirements. So if you were to have a look at this loss here, for instance, at 500 hertz, for instance, this person has lost 10 decibels. So with a hearing aid, we would want to bring that up from 10 all the way back to 0. And if you've got a loss over here of about 65 decibels, obviously we'd want to amplify that much more, because we've got to bring that all the way back up here to make that audible as well. So the idea of a hearing aid is just simply to amplify each frequency in proportion to the degree of loss that you've sustained, and then be able to balance that out as best we can. So as best as we can, and also as best as what you can tolerate. So the two need to go hand in hand. You need to adapt to the change of what you're hearing, because you've got conditioned to your hearing loss. You may have got used to not hearing high-pitched tones. You've now got to get used to hearing those sounds again. But the brain's amazing in terms of how it will adapt. It just needs to be given the opportunity, which means all you've really got to do is, if you wear the hearing aid, everything will settle down, the brain will adapt, and then we'll be able to gradually bring your hearing back up as close to normal as we possibly can. So these days, most people are able to get a very high degree of benefit from the use of a modern hearing aid.